Dave, are we getting close to?
What's that, Mike?
Good.
I'll start with her.
Yeah, come and say.
All right, Mike, it's 10. I think we should get going.
All right. Am I sharing my screen here correctly?
Yeah, right now we can see mostly you. Let me see.
Oh. Hold on. I'm doing something wrong then.
I think it's on my end. I think if you.
Well, hold on. I think I shared it. There's different ways to share the screen. So
I think you guys have this figured out.
Yeah, right.
Again, oldest. Oldest.
That's good, Mike.
am I in the corner there though?
What's that?
Is my video still in the corner up here?
Yeah, we can see your video in the corner. Yeah, I can move that though. Like,
Put on it.
All right.
we're recording and we're ready to go.
All right. So this is an update for October. I thought I would just kind of put a picture up here to remind us what things looked like in April. This was 800 some thousand cases in the US, and we were getting concerned about, we were had a lot more cases than other countries at this point. We were still had relatively low mortality except in big urban centers, and a lot of the cases were actually confined to urban centers were having the most trouble, most notably, New York at this time. Now looking at today, we went from, 2.6 million worldwide to 41 million. And going from, if we go back to that last slide, 840 some thousand cases to 8 million. So, a tenfold increase there, with a significantly increased number of deaths. Looking in the, bottom corner, they talk about the, second peak. Well, if you look at this data over time, it really doesn't look like there's been a peak yet. So it's just some short plateaus. So obviously things are changing worldwide. Locally in April, we went from 439 cases with only 39 in Missoula, a total deaths of around 140 back in April, to now, 275 deaths and significant number of increased cases, from 439 to 24,000. So we started to see a lot more cases locally in Missoula. The university has been, reopening, has contributed to a lot of those. We've also seen, significant increases in surrounding counties. Probably the most useful number is if you can look at the 7-day average per week, kind of gives you a better trend than the day-to-day numbers in low population density. That seems to be a better number than the daily increase is the, weekly average per day. So, our weekly average per day, I think, has been around 50 cases. If you look out at, Yellowstone, Gallatin, significantly increased number of cases. The percent positivity in Yellowstone County and Flathead County is around 1.5% positive positivity rate in the county. So if you look at Yellowstone, like almost 2,000 active cases, whereas, we look in Missoula, we have 1,750 active cases with a significantly higher population. So our positivity rate is around, I think, 0.5% right now. So it's threefold higher in Yellowstone and Flathead counties than it is here. So when we look at the total number of COVID deaths projected, this was, in the United States, back in April. They were predicting around 67,000 based on our current deal, up to 110,000 or 120,000. And now we've, far surpassed that number with, projections now out to, conservatively 389,000 deaths nationwide. These are considered excess mortality. I think there's a lot of people who say, well, these are people who would have died anyways, but that doesn't look to be true. I mean, some of those people probably are very sick and likely would have had other conditions that led to their death, but this is excess mortality. So, far worse than, any flu season in recent history. So, looking locally, again, this was back in April. They, had this prediction of around, up to 40 deaths in Montana based on those numbers in April. And now, that our current number of deaths in the state is much higher than that, with projections up to, 700 to, over 1,000. And again, it's kind of how quickly these people present to the hospital and get sick that, can contribute to that as well, is because if they overwhelm the system, our ability to take care of people is significantly impaired. So these are local cases. This was as of, last night. So, you're seeing that, around 50 new cases a day. The current active cases, 789, that takes into account people who are recovering. The COVID related deaths for Missoula County citizens, we've had, more than this, but some of these people are from out of the county who get transferred in, is 9. We have, they say current resident hospitalizations is 12. And out of county hospitalization is 11. So that, puts 23 people in the hospital currently. St. Pat's has around 14 patients that are in hospital beds and an additional 5 in the intensive care unit. So I think community had around 6 total the last time. So, we're getting kind of a large number of hospitalizations at this point. We're basically at our capacity at St. Pat's right now for standard level of care. We start having to do adjustments soon if we're going to accommodate more patients, and we have had to turn away intubated transfers from other places because we don't have any ICU beds at this point. So the hospital is going to be decreasing elective surgeries, and this next week's surgery schedule regardless was light, but I think that's going to be an ongoing thing. Is complex elective surgeries have multiple day hospitals stays associated with them, which really decreases our number of ICU beds for a lot of the heart cases. So I think they're going to look at decreasing those. Interestingly, when you look at the positivity by age group, by far and away, the 20 to 29-year-olds make up a large percentage of this. Of the current active cases, around 70 some are just from the university. So that's a pretty big number. The second population is the 30 to 39, and then so more than half are from under 40 with the new cases. So this has changed recently. Oh, I think before I go on to that, I think I had one quick. I just got this the other day and I didn't have time to put it in the show, but this is an update from regional facilities. So compared to St. Pat's, they said total COVID hospitalized was 18 on the 20th. And if you compare that to like the Billings Clinic and Great Falls, you can see the significantly increased numbers of hospitalizations. If you look at Cadillac and the Tri-Cities, which isn't on here, they've basically stopped cohorting patients because everyone is basically positive in the Tri-Cities that is hospitalized right now. So, that's concerning. You look at the number of ICU, that's basically Great Falls' entire ICU is COVID, with 16 on the vent right now. Billings Clinic, slightly less ICU and vented patients. but you see there's quite a few vented patients around the state. You know, as of today, St. Pat's, I think, has 4 vented patients. 4 vented patients, I think, right now. One is prolonged. They've been on the ventilator for around 22 days. You can also see some of the other associated things going on. They're canceling or delaying surgical procedures in Great Falls. They're trying to get traveling nurses in Billings to cover. If you standard take care of a patient on the floor, the nurses are 4 to 5 patients per nurse. And right now with COVID units, most of the time it's 2 patients per nurse. So you have the increased nursing demands. And at the same time, you have nurses who are getting quarantined for exposures. Maybe a lot of these are actually occurring outside of work. So you have providers testing positive or getting quarantined because of family members, which cuts down that supply even farther. So you can see that there's, around the state, pretty significant impacts right now in the hospital system from this. So locally, the biggest thing that's changed, and probably some people are aware, is that we're seeing cases from the long-term care facilities. And as of yesterday, the village now has almost 60 positive cases. So that is probably going to impact us a lot. I think we've been seeing a lot from the Springs at all. I think everyone knows that. It's a little bit different at the village, where it's skilled nursing. They may be able to prevent some of these people going to the hospital by doing more intensive management there. And they're working on a plan for that right now, is my understanding. I spoke with them yesterday on an unrelated issue when this all kind of came up. I think they'd reported 30 positive earlier this week, but apparently that number was much higher. I think 58 or so is the official number as of yesterday morning. So we can expect that some of these patients will need to be transferred, and that brings up some transfer issues. A skilled nursing facility, usually there's a doctor's order to transport a patient to the hospital. So we're probably not going to be able to, stay on scene and discuss whether this patient still needs to go or not at that point. And so what I've really asked them to do is make sure that a doc-to-doc conversation happens before the transfer to try and prevent people from going to the hospital unnecessary, and especially try and prevent us from having to take patients, on a two-way, a round trip, basically, rather than just to be hospitalized. I think that we're going to be really looking at patients who are comfort measures only to try and stick with that care plan for COVID, rather than have them rescind that at the last minute, is my hope. Because if they're sick enough that they're not able to be managed at the skilled nursing facility, that would likely mean additional therapies would be something like a ventilator. In patients who are limited interventions, so they do not intubate or do not resuscitate, but they do want limited interventions, there may still be benefit for hospitalization for high flow nasal oxygenation or non-invasive ventilation. So there are still things we can potentially be doing for those patients. But again, the benefit is probably low once you get to the point that you need high flow oxygenation. So the nursing homes are really going to be, they're trying to set up a meeting right now with the hospitals to develop a plan for how they go about deciding who gets transferred to the hospital, and to try and make that as efficient as possible. So I put this up again just to remind us that, early in the infection, people may be pre-symptomatic to mild symptoms, and then they get sick later in the course of the illness, where they start developing shortness of breath and abnormal chest x-rays. That's occurring, around a week into the illness. And then the people who are going to deteriorate from there, that occurs around 10 days. So initially, a lot of people feel poorly. They may have some subjective shortness of breath with normal oxygen saturations and minimal chest x-ray findings. But once they start developing worsening chest x-ray findings and worsening oxygenation, those are the patients who are going to start benefiting from additional therapies. This was from early on in the epidemic, and some of these things have gone out the window, but for sure, steroids and remdesivir, when people start to have an oxygen requirement, have some benefit. Although they've just recently questioned remdesivir in a huge study, it looks like it may be of minimal benefit, more like Tamiflu. So remember, still, although there are cases where this can be aerosolized, primarily this is spread by large droplets. So putting a mask on the patient is by far the most important thing, next to you wearing a mask at the same time. So the CDC recently changed the definition of a close contact. So it used to be less than 6 feet for 10 continuous minutes, but now it can be, multiple episodes over the course of a day or multiple days where you have short duration contacts. So they think the short duration contacts are probably more important than they originally recognized. And so that's why the CDC has changed that. It came out of several specific cases, and one of them was a jailer who had less than a minute contact with an inmate like 6 or 8 times over several days, who developed COVID, with that being the only known exposure. So aerosols, we worry about that, especially with nebulizers, but suctioning, intubation, non-invasive, those things are considered aerosols. Any liter flow from the wall, 0 to 15 liters is not considered aerosolizing. There was some concern the other day from the emergency room that was not the case, but it really has not been shown to aerosolize significantly. If their patient's wearing a nasal cannula, I would, keeping them a mask on that patient is good. If you're able to put it over a face mask, I think that's okay, especially one of these open face masks. If it's a non-rebreather, I don't think that's super realistic to do sometimes, depending on the device. So, but I know I've been trying to reinforce this with staff at the emergency room. There was some confusion on this a while back, and kind of a rumor got started at the hospital that anything over 6 liters was considered aerosolizing, which is not the case. So if you hear that, that's not the case. So again, the incubation is anywhere from 2 to 14 days, and the average from big studies looks like it's just over 5 days. Around 6 days, people can start feeling a little bit short of breath. The patients who are going to need to be admitted, their average is around 8 days of illness, and ICU admission average is around 10 days, because as the host inflammatory process gets worse, they start having deterioration. Again, we don't need to go over this too much, but remembering it's a lot of vague symptoms initially. About half have a fever initially, 90% over the course of their illness. Cough, fever, and shortness of breath are the most common symptoms, but loss of taste and smell may be more specific. GI symptoms are common, muscle aches, fatigue, and then GI, those are the expanded symptoms. The risk factors again are age over 55, male gender appears still to be a risk factor, hypertension, underlying lung disease, cardiovascular disease, and diabetes. 911 is still doing this screening, but again, it's really, less important now. We should really be wearing PPE on almost every patient. We've had a ton of asymptomatic or minimally symptomatic patients who later get diagnosed. We had 2 pediatric traumas recently, both were positive. So just be diligent about wearing your PPE. Again, distance is our friend with this. The minimum safe distance of 6 feet. Remember to don your PPE correctly. There's been questions about eye protection versus face shield. My preference is always a face shield because the face shield protects the outer surface of your mask. So if you're going to wear an N95, some people are wearing a surgical face mask over the outside of the N95 to protect the outer surface of it for reuse. And I'm doing that for like traumas and any intubating kind of situation. I'm going to wear the surgical face mask over my N95. The recent discussion has been around jumpsuits, and City Fire has gone to jumpsuits, and it looks like we're getting those from Messi as well. There are aspects of the current CDC PPE guideline for using that. That'll require some training for donning and doffing, as well as what is it, Dave? Is it the sterilization gun? Is that what that's called? Smith?
Yeah, buddy, we're using the COVID killer guns on those for any light contamination, and then washing them and drying them on hot if they get any visible secretions on them.
I know everyone hates the gowns, but even with the jumpsuit, if you're doing something that like a code, I would still consider wearing it. I know it's annoying, but anytime that risk is higher based on the intervention you're doing, I would think about it. But really the doffing is the most important part of this. So we'll need to do some practice with the jumpsuits once we get them, and we'll get that out so that people are familiar with it. But remember, the doffing is the most important. So I use hand sanitizer over my outer gloves, and then I break away the gown and remove it into itself, rolling it up into itself, and then I re-sanitize my hands before I take off my face shield and mask or respirator if I'm removing that. So any questions about PPE right now? I know a lot of this is review, but really it helps me to rethink about this stuff all the time too. So again, don't wash your face, use appropriate hand sanitizer. I will say that we're pretty well off, but I would be cautious about some of the hand sanitizers that are not in the medical setting, because some of these things turned out to have significant amount of methanol in it, which can cause toxicity through the hands. Sometimes if you have a product you haven't seen before, it might be worth looking up to see if it's one of the hand washes that might contain methanol. A bunch of this stuff was labeled made in the United States, but it was actually made in Mexico, it looks like. So
Like this McAvoy, I got a question just about like K95 versus N95 surgical masks. Anything new on like how whether they work any better?
no, I still wear just a simple face mask pretty much all the time. I am only really wearing the N95 if I have a patient who is getting, high liter flows that I might need to intubate, or I'm actually doing an intubation or resuscitation in someone who could decompensate. But in general, for like a COVID patient who feels short of breath, who's, on a couple of liters, I'm just wearing the surgical face mask with the shield over it. If you wear the N95, that's fine. The N95 is preferred. The KN95s are probably not quite as good for medical settings. And there are some new N95s out there we're looking at. Is that right, Dave Smith?
No.
Okay.
We've got the same stats we got. We're kind of just take what you can get with the N95s right now with the supply chain.
Yeah. I know the hospital is looking at it. It may be the hospital that's looking at a new one then. I haven't seen it yet, but it's some kind of gel thing. So
Jesse just ordered one of those for all of our employees. They're reusable, I think.
okay. No, I think it's good to be careful about some of this stuff and really make sure it's been tested, because some of the stuff that came out early has not had any kind of testing and is probably, not, while it looks like a good idea, may not be quite as good as we thought. So again, with the management for us, it's going to be supplemental oxygenation is really our primary deal. Is we want to, keep their sats above 92 if we can. So there was this thing about avoiding steroids unless COPD and asthma, but now they've actually found specific indications for dexamethasone. And it's 6 milligrams of dexamethasone daily for patients who have any kind of oxygen requirement. It's less beneficial once they're on the ventilator, but they have shown benefit with that. using the MDI instead of the nebs if we can. Sub-Q epi is still an option if we need it. And remember that remember all our Lego connections that we're doing with bag valve masks to make sure that the viral filter is in there, even with the BVM, but also once they have a supraglottic airway or endotracheal tube. Again, for codes, I would go straight to the supraglottic airway just because it's so much faster and more successful on that first chance. And then if you do have to intubate, it should be as controlled as possible by the most experienced operator. So I just put in a reminder to keep tidal volumes low and to use PEEP, because those are the things I think we sometimes forget about with the bag valve mask that we don't start thinking about till we start getting the ventilator. So not, milking all 1,200 milliliters out of that bag into someone. We want to make sure we're using somewhere around 400 to 500 milliliters probably. So just an update on the specific therapy we touched on already. Chloroquine, really probably not that beneficial at all. And there's no hospital system I'm aware of that is using this as a therapy. Azithromycin, they had some stuff they thought was maybe helpful, but it doesn't look like it's of much benefit. There was this talk about Pepcid being of maybe some benefit, but it doesn't look like that's borne out. Dexamethasone, again, for people who have an oxygen requirement, same with remdesivir. There's not much benefit to remdesivir in patients who don't need any supplemental oxygen. So this big study recently came out that looks like it's probably of less benefit than we would hope anyways. So it's kind of lower on my treatment deal. It's fairly restricted as well. I think only we have like a specific pathway to go through to get it at the hospital, and it's not available at all hospitals. Convalescent plasma looked like it might have some benefit, but again, it looks like it's very low. A lot of media has been focused on this monoclonal antibody. I suspect that Donald Trump has a fair amount of stock in that company, but there's not been big trials to show how beneficial that is. There are these things called spike protein inhibitors. It's basically like a part of an antibody, so it's not the whole antibody, or a protein that is similar to the ACE receptor that the spike protein will bind to. That is looking like another potential therapy. And again, there's multiple vaccines out there. The one that's farthest along is actually the one in China, because they've had the most continuous effort on it and it's had the most study, and it looks like it's probably of some benefit. A lot of countries are going to be going with that. I would still wait and see. I never know how good the science being done is. It looks like, I guess we can see what happens, because I think Venezuela is going to start using it. So the vaccines in the United States, there's like a consortium that has one that's fairly far along, and AstraZeneca. I think those are the two that are in phase 3 right now that are the farthest along, and we'll see what's going on. They've had a couple of people have some weird side effects, but they don't really know if that's vaccine related. They have to have such a large group of people to determine the safety of these things and the effectiveness, that it's always a question as to whether it's if you just have one case of something, if that's vaccine related. So we'll have to wait and see. All right, so non-transport of patients. So this has come up, and I think this is something that we should think about doing right now. And we have a 2-page document that is fairly complex, and it's complex for a reason, because I think this is something we have to be careful about medical legally, as well as, for taking care of our patients. So there's a whole checklist to go through to determine if someone is a candidate to potentially be not transported, and it still has to go through informed consent. So if they meet all these criteria and they still want to go to the hospital, we can say that it's unlikely that they're going to be able to do, or they're unlikely that they're going to be able to do anything additionally for you, and that really the best treatment is time at this point. And if they still want to go, we can't refuse to transport patients at this time. That could change, but I think that there are patients we're getting who are candidates for this, and going through this with them in medical control as part of that, I think is pretty reasonable to be involved if questions come up. So Dave, any comments on this? McAvoy?
No, Mike, are we gonna try to again expand this to include just a little bit more for the nursing homes?
Again, I think that it's going to be tough to do for the nursing homes because none of the patients in the nursing home will fit these criteria.
Exactly.
So it's a different process. And I'm trying to make that happen at the sending level rather than at our level. So we don't have to argue with staff. I think right now, everyone's operating at like peak levels of frustration. So minor things we say or do can be interpreted really differently. And sometimes it's hard to, tell what we lose some of the cues, the social cues when people wear masks. So there have definitely been a lot of interpersonal interactions in the hospital, but also in EMS that have led to, conflicts between caregivers. So as much as we can be diplomatic about things, and even if something is frustrating to us, we, need to do our job and be professional about it and realize that there's going to be, cases where we could have done something different that may have been better, but we just need to get through those things and then readdress them at a systems level to try and prevent those things. Because getting in an argument on scene with someone is not going to benefit anyone. And so I know it's difficult and frustrating, but we need to get through that. So we're trying to work with the nursing homes to develop a protocol for who they send and a doc to doc, so that discussion is out of our hands. I think will be helpful for us. It's different at places that don't offer skilled nursing. So if there's not skilled nursing there, I think potentially involving medical control in those ones may be of more benefit than the nursing home ones. The places like the Springs that have patients who are on comfort measures and now they're wanting to send someone, I think there may be more we can do there with talking to family or having family talk with the medical control person at the receiving facility, because if those people are on comfort measures, really we probably want to try and avoid transporting them. Again, if they're do not intubate patients and they're having some distress, there may be things short of mechanical ventilation we can do for them. So just because they're do not intubate doesn't mean that we don't take care of their acute medical conditions.
And Mike, how ready are the docs at St. Pat's to be receiving more phone calls from crews in the field? Because I know we had a problem. The community just didn't go over super well when we did that.
So I haven't heard back from the community group, but the people in our at St. Pat's are aware that this is something that we're going to be doing. So
yeah,
Not putting the doctor on call, like that's just their job for now, or?
it go well.
When they call the field,
Yeah, well, they're talking about talking to patients, family.
Hey, Andy, I think Mike, did you hear that?
I couldn't hear that at all.
Kathy, you want to say that again?
No, I mean, just for like to get us through this, like a doctor on call, that's just their job. Instead of us calling someone in the ER, like, there's somebody that, volunteer. I don't know, just somebody that we have a line to, that there's somebody always there, so we don't have to bother the ER doctors.
Who was that? I'm sorry.
That was Hudoc asking that question.
No, I heard the question, but I didn't see who was she wanting us to call.
Oh, I just thought, just something entered my brain. It's like, have you guys thought about just having a doctor on call that's not an ER doctor at that day, so that we're not bothering the ER? That we just call a number and there's a doctor there that's, I don't know, it's just a thought that just entered my brain.
Yeah, no, I think it's a good thought. I just don't know that we have the resources to maintain something like that 24 hours a day. So, with, trying to find a physician pool that would be able to cover that. And to be honest, I think that the advantage of using the emergency room is, that's where the patient is likely going to be headed if they do end up going, so that there's investment on the part of the emergency care provider to be involved in those decisions.
Mike, is there any change in the thought about, and Dave Smith, this is a question we've been talking about, change in resuscitation in general for COVID positive patients beyond what we're talking about right now?
Dave Smith and I were talking about this, and I think that what we need to do is kind of see what happens right now. If we start getting a whole bunch of codes in the community, I think we're going to have to go to some kind of modified response for COVID patients, like known COVIDs, just because it does put a lot of providers at risk for probably a low yield scenario.
Are we not expecting, Mike, that within a week, Village will have a surge? Is that, I mean, that's probably pretty accurate, right?
Yeah, I think they're having a surge right now. It's just a question of the people that are newly diagnosed are the people in that group. Again, it's going to take 8 to 10 or probably somewhere between 6 and 10 days for them to get really sick.
That's what I mean. Like, we're expecting within a week we'll have a surge of codes there. Is that seems accurate, right?
And I guess we need to look at what that modified response would be. We were talking about just a single engine and ambulance response for that. Just so you guys are aware, we got a grant through the hospital for Lucas devices in the hospital for COVID positive patients. So that's the security guys have all been trained on that. And we have a Lucas in the ER. There's one in the ICU and there's one on the 5 South right now, I believe. So I don't really have a specific answer about what the trigger for that would be or exactly what that response would look like. But my guess was it would be a single engine rather than 2 engines.
Yeah, Kremkau, we got just a basic outline of what that is going to look like. We'll just bat that around, I think, over the next few days and this weekend and get that out to people maybe next week. And talk about the trigger points for implementing that, if that sounds good.
Yeah, I think that would be good just to have done in advance of needing it, so we're not creating it on the fly. And I know we've been talking about it some, but it'd be good to get that out so people can see what it looks like in advance rather than having to train it at the last minute. So. I couldn't hear that. I'm sorry.
I think that was background noise.
Okay. It said Ben Murphy. So, all right. Let's see, what else do I have? Yeah, again, I think everyone's doing a good job of notifying the receiving facility that it's and we're basically using COVID positive on the thing now, which I think is fine given the situation. I would try and keep family members out of the transport vehicle if possible. We're doing a good job of isolating the driver from the passenger compartment, it seems like. Has there been any issues with the transport or decontaminating the ambulance?
Jimmy? No, not really. It's just time consuming, but that's just the way it is.
Yeah. We have the same problems in the emergency room right now. So if we have a known positive patient, the room, we measured the air handling of every room in the emergency room. And so depending on what that is, we may not have a room available for like 45 minutes to an hour after that patient has gone, which is really frustrating. So unless it's a negative pressure room that turns over faster. But.
Okay, and that brings up a question that I have about this 45-minute wait time. Both facilities
whether the ER is full or not, maybe it's just perception on my part, but it seems it takes 10 minutes or longer for these guys to get out here with the bed. And, you know, we have calls dropping and stuff like that. I know if the ER is full or, you know, it's just bonkers in there, that's one thing. But if we wait 10 minutes, we go in there and everybody's standing around BS, and that's quite another. And this is at both facilities from time to time. It's not a constant thing. But then once this new search starts and we start waiting 45 minutes, we just gotta figure out a way to keep us from going bonkers sitting there in the ambulance bay.
Well, if we get to the surge level stuff, the ambulance bay will be closed off and there'll be additional treatment area out there. So if you guys have seen, we have those temporary walls all stored on the side. We have the ability to create a number of additional beds in the emergency room. Although the issue we're running into now is that we are so short-staffed, we may not be able to staff those. So I'm not sure what the amended plan is with the surge committee, but I know that staffing is looking like it may be our critical shortage for the surge. So I know that they've hired a bunch of additional nurses, but I think it's, you know, if you get more providers quarantined, then we may be having people who are, you know, mildly symptomatic coming to work. So, which is going to be a frustrating situation for everyone. So
I have a question, this is Kathy again. How do you picture now that it's flu season and combine?
I don't know what to expect, because if you look at Australia, which, you know, because their seasons are shifted from ours, the flu season they've had is like close to nothing because people are doing all these additional precautions. People are doing all these additional precautions, and it looks like that's not only effective for COVID, but it's significantly decreased flu transmission. So the flu season could be very light. So.
What's Americans made of
I think that, I mean, it'll be interesting to see because I don't know for sure what's going to happen with any of this. And I think some of this stuff is ultimately going to change with the election too. I think there may be dramatically different responses depending on who gets elected. So, but.
Yeah.
It doesn't make the virus go away.
No, but
yes, when the news cycle changes, viruses die off really quick. No, I'm just kidding. That's not true. So.
Hey, Mike, John
Yeah.
Andretti. I'm sorry I missed the first part of this, but are these documents you're showing available to us?
The documents as far as?
What you're showing on your computer?
Oh, the slideshow?
Yeah.
Yeah, I can send it to McAvoy and Smith.
Okay.
So in fact, I'll add in that hospitalization thing too here while I got it. I just got that the other day.
Thank you.
So.
Hey, Mike, I just stepped out for a second. I don't know if you covered this, but just in terms of our contact tracing, like if we have an exposure, if we have an employee who tests positive, I just want our folks to know that I always call Mike and then I talk to the Med 10 people. I know it's frustrating because sometimes it seems like it is variable at times, but we're doing our best to be cautious. And Mike, I don't know if you have any follow-up for people on how we're going about this.
Yeah, so I will say I would be patient with the health department. They're doing the best they can right now. They're tracing, they have over 1,600 close contacts to trace. So I suspect that's occupying most of their time. And the reality is they're not going to be able to trace all of those cases because there's just, too many. So, and I think they did something with sending out letters, if people have seen that, and the letters are often getting there after, they're outside of the quarantine period. So the whole thing is kind of a disaster, but they don't have like the resources or staff to do half the things they're already doing. So I would be patient with them. So.
But in general, what we've been doing, like if we have a positive employee, they get quarantined and then typically their partner is getting quarantined. But again, I talked to Mike immediately about that when that happens. I don't know if you have any follow-up on that, Mike, about how those conversations go and before this, because we can't wait for city county health.
Yeah, no, I think we should be proactive right now while we have staff. We may have to change, if we get to, crisis standards of care, which is not impossible. We may have to say that, hey, I know that you had this close exposure, but you're going to work unless you develop symptoms. And then at some point, a lot of places have said, hey, if your symptoms are mild and you're towards the end of that thing, you can probably work. So, those are things to consider, but ideally, we, are proactive rather than, reactive. So, and we should be overly cautious right now, because if we get, multiple providers sick because we let someone come to work, then we're in a bigger problem. So.
Any other questions for Doc? Mike, anything else?
Oh, I don't have a ton of other things. There's, a lot of work going on. I'm working on a project right now to get people home from the emergency room with supplemental oxygen if they're low risk. So they'd have to meet a number of low risk deals, and then trying to arrange to make sure they have pulse oximetry and some kind of telemed follow up at a minimum is one of the projects I'm working on. So there's another, and the other thing I'm working on is this nursing home issue right now. So trying to make sure that there's at a minimum a doc to doc call, but ideally that there's an agreed upon transfer policy for both the hospitals that's the same. So.
Great. Hey, Dave Smith, anything else on your end?
We're good here. Thanks for the presentation. That was great.
All right. I just forwarded that presentation to the Daves. So good luck out there. If you're running into situations that, are difficult or unexpected, or that where you think that we need to start trying to solve problems, do the best you can in the situation, but get those situations to, one of the supervisors or the EMS coordinator so that we can try and arrange, a solution for it. And I guess if there's places where we're getting a ton of cases from, or there's a transfer policy that seems maybe not in the best benefit of people, get that information to us. You guys are not only, out there providing care to patients, but you're providing that kind of medical intelligence to us so that we can adapt our response. And I'd encourage everyone just to remain flexible. This is a difficult situation and stuff is going to change rapidly. So this is where it's going to put a lot of stress on us to adapt to this thing. And the quicker we can adapt to it, the better our response will be, rather than just sticking, boring ahead with a ineffective response. We want to be adaptable. So.
Anybody else got questions? Okay, this is all being recorded. I'll put it on our YouTube thing there, and I'll put Mike's presentation on there as well. Thanks, Mike.
Thanks, Mike.
See you guys.
Thank you.